This conference will now be recorded.
All right, so face and neck injuries. So not something that we do a lot of facial stuff, but really not so much as neck. You'll be honestly surprised on the amount of times we get called them like traumatic injuries, or we think cervical spine, neck injuries, and we do apply C-collars, everything else, and they come back completely negative. However, any kind of pain or mechanisms that's really there, you really should be collaring patients. However, with the state of New Hampshire, and I'll even throw in Massachusetts and Maine as well in this, we do have the advanced spinal protocols that allow us to rule out C-spine and not use a cervical collar. We still want to consider a mechanism of injury, even though they might not have any pain. We still want to make sure that we're addressing that. So let's just pass all the competencies we're going to cover here. All right, so obviously with the introduction, the face and neck are frequently subjected to traumatic forces. So we do see this happening, whether it be diving injuries to motor vehicle accidents, to just rough housing, whatever it may be. Our face and neck are frequently subjected to those traumatic forces that are out there. So soft tissue injuries and fractures to bones are common and sometimes life-threatening. So we talk about the face itself. What is one of the most fractured bones in the face? What do you guys think it would be?
Jaw.
Yeah, the jaw, and then also the most fragile bone.
Nose.
Nose or the orbit. The orbital, yeah, like Matt O'Connor just said too. The orbital fractures are one of the weakest bones that we currently have, and usually sustain significant traumatic forces. You know, like just falls alone. We go to a nursing home, we find the face completely bruised up. Sorry, I'm just finishing up the attendance as we talk here. Try to miss somebody. And we get there and we see those raccoon eyes. So remember, that was one of the significant indicators that we would come in contact with a patient that would have significant trauma to that orbital area. So the assessment technique we're going to utilize for orbital or facial injuries is just palpating around the orbit to see if you can feel fracture and maybe increase the pain that's actually there, and kind of find out where the fracture could potentially be located. Go back one here. So obviously, with penetrating trauma to the neck may also cause severe bleeding. Remember that we have internal and external jugular veins as well running through there. We also have it's a very vascular area around the neck. So a lot of other veins that are kind of hidden underneath the skin that we can't see, to our jugular veins, to the carotid arteries that run through there as well. So we got to make sure we're paying attention to those. And if there is any kind of major bleed, stop the bleed. Please do not use a tourniquet. Do not use tourniquets for those. And then open injuries also allow air emboluses to enter the circulatory system, which is why we need to put occlusive dressing or a dressing of some sort over the wound to protect air from getting in. Air embolus in the system can cause significant damage, and will be and can be fatal. And then also may stop or slow blood flow to the brain if we have that blood flow coming out. Remember that our brain itself needs three things to survive, and one of those three is blood, oxygen, and sugar. And if you lose that blood and that oxygen transport, we start becoming very hypoxic, and the brain can be having an anoxic injury. So as an AEMT, your objective when treating a patient with a face and neck injury include prevention of further injury. So particularly in the cervical spine, then managing any acute airway problems, controlling bleeding. If we have major bleeding, the patient will die. We got to stop the bleed, right? But if we don't have an open airway, the patient is also going to die, so we have to maintain that airway as well. Whether that be using airway adjuncts up into a king airway to kind of keep the airway open if they don't have a gag reflex. So a little bit about AEMT, kind of review bones and landmarks. Remember that the head is divided into the cranium and the face, right? So top, head, cranium, skull, going down into the facial bones that are there. How many facial bones do we have? Give me a number. Anybody want to answer that one?
7?
6,
6?
7, 14, right? So we have 14 different facial bones. Right. So with that being said, we have the facial skeleton, which is comprised of 6 of the major bones, but there's actually 14 total. Remember the nasal bone, the 2 maxilla, 2 zygomas, or what used to be called the zygomatic bone, and the mandible. So the mandible forms the jaw and the chin, right? So the motion that occurs in the temporomandibular joint, which lies just in front of the ear on either side of the face, right? So you can kind of follow that up, right? Just by the ear itself. You actually feel that in yourself if you want to palpate. And you kind of just go up, up, to the point where you can open and close your mouth. You kind of feel that temporomandibular joint that's sitting right by the ear in the corner of the face. So, as you can see in the photos, right where the arrow is pointing now. All right. So the mandible forms the jaw and the chin, right? We talked about that there as well. The semicircular hyoid bone is the only bone in the body that is not attached to another. It's kind of the only floating bone that we really have. And in the superior aspect of the neck, just below the mandible. So that's going to sit kind of hard to show in this one here, but kind of underneath here, underneath the tongue area. We're going to find that. So the principal structures of the anterior region of the neck include the thyroid and cricoid cartilage. Not so much important for the AEMT, but very important for the paramedic level, right? Because this is actually where surgical and quick trachs and crikes are going to be done. So very important for a medic level to understand that landmark, but still good for you guys to understand as well. There's a lot of vasculature that runs on either side of here, the trachea as well. And it can also run directly over that with veins. I've seen that in people with that as well. It can be very dangerous. You can cut into that. So the posterior structures of the anterior region of the neck include the thyroid and cricoid cartilage, the trachea, and numerous muscles and nerves, right? And you can see the cartilageous rings on the trachea here. Remember that in a pediatric, that's not going to be fully developed, so that's why it's more pliable and able to bend depending on the angle of the infant's head. But in an adult, the chances of occluding this off are very less likely due to the cartilageous rings that are fully developed. So the firm prominence in the center of the anterior surface, commonly known as the Adam's apple, right? So you kind of see that right here. This is the upper part of the larynx formed by the thyroid cartilage. The cricoid cartilage is a firm ridge of cartilage found below the thyroid. We talked about the cricoid cartilage down here and the cricoid rings going down. Lateral to the vessels and nerves lie the sternocleidomastoid muscle. That's the major muscle that runs from up here and kind of goes straight down through the neck, right, as well. So with the eye itself, a lot of parts to this. The globe-shaped approximately 1 inch or 2 centimeters in diameter, which is located within a bony socket in the skull called the orbit, right? We talked about the orbital fractures. So on the next page, I'll kind of show you a little bit more. The next slide. The ocular motor nerve innervates the muscles. Remember, the ocular motor is one of the 12 cranial nerves. Innervates the muscles and carries the parasympathetic nerve fibers, right? The optic nerve provides a sense of vision. The orbit, which forms at base or the floor of the cranial cavity, directly above it are found in the frontal lobes of the brain. The eyeball, which is the globe, keeps its shape as a result from pressure from fluid contained within the 2 chambers. The anterior chamber is filled with aqueous humor, and the posterior chamber is filled with vitreous humor. The sclera extends over the surface of the globe. So you can kind of see, looking at the photo here. If you were to have head trauma, what would cause vision changes? What part of the brain? Or what lobe? If you were to have vision issues. Does everybody else agree with Matt? Perfect. Yes, the occipital lobe. That controls our vision center. The inner surface of the eyelids are exposed surface, and the exposed surface of the eye itself are covered by the conjunctiva, which keeps it moist by fluid produced by the lacrimal glands, right? So why would lacrimal glands be important to us when it comes to toxins? What is a toxin that would cause us to have excessive tearing? Try to put some more EMS into this lecture for you versus just AMP. Yeah, great, Matt. It's awesome. Good job. Organophosphates. Remember, sludge them. Lacrimation. All right. So some people are born with pupils that are unequal. This is called anoscoria. So you may see someone that has unequal pupils. If you had it normally, if you were to do an assessment and find someone with unequal pupils, you would think head trauma, right? So you want to make sure you ask them, especially if they're learn oriented, do you have any history of anoscoria? You ever had that before? And that would give you an indication of having those unequal pupils. If not, it could be a head trauma, it could be a stroke, things like that to pick up on. All right, so the ear obviously very complex, a lot going on inside the ear. So this is a complex organ associated with hearing and balance, divided into three parts. There's an internal ear, which is composed of the pinna and the external auditory canal. The middle ear contains three small bones, the malleus, incus, and the stapes. And the inner ear is composed of bony chambers filled with fluid. So there's a nerve as one of the cranial nerves called the vestibulo or cochlear nerve, which I'm trying to see if it's actually on this photo here. I don't see it listed, right? Oh, there, cochlear nerve, the vestibulo-cochlear nerve, these two nerves here. That's part of your 12 cranial nerves as well that involve hearing as well. So kind of keep that in the back of your head when you're doing your assessment. Can the patient hear you when you do your neuro assessments? All right, so pathophysiology. Injuries can lead to partial or complete obstruction of the upper airway. Contributing factors to that would be direct injury to the nose, mouth, larynx, or trachea. Teeth or dentures may become dislodged. Swelling that accompanies injury to the soft tissues. Injury to the brain and or cervical spine. Injuries to the great vessels in the neck can cause significant bleeding and pressure on the upper airway. And cervical spine injury. Remember that we did just discuss that we have the internal and external jugular along with our carotid arteries that have exposure, right? So these can be injured or damaged. Not to mention you can have tracheal damage as well or tracheal crushing, right? So when you're doing your assessment, we have to make sure we're palpating. So when you do a trauma assessment, actually touch and palpate the trachea to see if it's either deviated for one, is deviated, is it caused by traumatic injury? Is it caused by a pneumothorax? Or does it feel crunchy underneath your skin, underneath your hands when you're palpating, or you have tracheal fractures? The face and neck injuries are the very common, as you can see here in these photos. You can almost see kind of like the degloving of the scalp to significant head trauma, as you can see on the right picture versus the left, where we have potentially had a fall of some sort in there, it looks like. So if you're looking at the photo on the left, you can see where the avulsion is here and the skin being pulled back, but you're starting to see some bruising down around the eye. So could this have been a head strike on a fall, causing an orbital fracture, right where there my arrow's pointing now, right? So these patients are obviously going to get CTs as well to make sure there's no fractures, X-rays and CTs. So the area, so face and neck injuries are common where the area is extremely vascular. So swelling may be more severe. Bleeding bleeding from penetrating injuries may also be heavier, and blunt injuries may cause a hematoma. So the presence suggests a potential or more severe injury. With this, there could be more internal stuff going on, more like a head bleed, things like that as well. So these patients here need to get CTs stat. This guy's gonna need surgical intervention. What is one question that's very important you need to ask when you have an elderly patient that fell?
Do they take any blood thinners?
Exactly. Do you take thinners, right? Anticoagulants. That's a very important question because this typically could be a simple laceration or avulsion with a patient on blood thinners could have a significant internal head bleed, whether it be a subarachnoid or a subdural type bleed. So maintain a high index of suspicion when patients present with closed soft tissue injuries. Remember that risk of airway compromise and blood in the gastric is a gastric irritant. So if we have injury to the face and we're getting blood down into the stomach, it only takes about a tablespoon of blood as well to cause someone to start vomiting. And yeah, Justin, I saw your post as well, history of osteoporosis. Another very important question as well. All right, so facial fractures. They occur when facial bones absorb the energy of a strong impact. Right? So a magnitude of force required to fracture the maxilla will produce a closed head and cervical spine injury. That's how much force it will take to break the maxilla. So protect the cervical spine and monitor neurological signs, specifically level of consciousness. Ask them to repeat questions. Check short-term and long-term memory. Repeat the questioning with them, right? Do that neuroassessment. Can you touch your finger to your nose? Can you grab my hands and squeeze? Even checking CSM, you're checking neurological deficit. Is there any posturing, whether it be decorticate, cerebit? Protect the cervical spine and monitor the neurological signs that are there. Signs and symptoms would be a deep facial laceration, pain over a bone, echobosis, swelling, pain on palpation, crepitus, misalignment of teeth, facial deformities or asymmetry, instability of facial bones, impaired ocular movement, and visual disturbances. Nasal fractures are the most common facial fracture as well, one of the most common between the nasal and the orbitals, characterized by swelling, tenderness, and crepitus. Remember that the nasal bone starts up high and turns into cartilage after that. Deformity of the nose usually appears as a lateral displacement of the nasal bone, often complicated by presence of an anterior or posterior nosebleed or epistaxis. The mandibular fractures are result from massive blunt force trauma or lower third of the face. Right, so I'll show you some different fractures, maxillary fractures in the next slide. The fracture site is most commonly located at the angle of the jaw. We're going to find that. So the site of multiple mandible fractures, usually the chin, suspected in patients with a history of blunt force trauma to the lower third of the face presenting with dental malocclusion, numbness of the chin, and inability to open the mouth. So the point tenderness and pain on motion can identify injuries that the patients may not have otherwise reported, right? Let's take a look at the next slide here. So you can kind of see where your maxilla or maxillary fractures would be over the maxilla here, going up over the nasal bone and back around, or across here, the top of the eyes, right? So let's go over a little bit more in depth of these ones here. So these occur with mechanisms that produce blunt facial trauma, massive trauma. So the first one we're going to talk about, number one, is called the Lefort fracture. So the Lefort 1 fracture is a horizontal fracture of the maxilla, as you can see here. This is called the Lefort 1. It separates the hard palate and the lower maxilla from the remainder of the skull. That's bad. That's a significant fracture. A Lefort 2 fracture involves a nasal bone and an inferior maxilla, which separates the nasal bone and the lower maxilla from the facial skull and the remainder of the cranial bones. This is a Lefort type 2. And the top one, being a Lefort 3, right, is a craniofacial disjunction, where these just basically separate. The nasal, so basically what's happening here is they separate the entire midface from the cranium. So this is a fracture of all the midfacial bones going straight across. So Lefort 1, Lefort 2, Lefort 3. Orbital fractures. So example would be a blowout fracture. Signs and symptoms would be double vision, loss of sensation above the eyebrow or over the cheek. The patient may have reduced sensation to areas innervated by the infraorbital nerve. And massive nasal discharge, impaired vision, and paralysis of the upward gaze may also occur as well. Zygomatic or zygomatic bone fractures commonly result from blunt trauma in motor vehicle accidents and assaults. Signs and symptoms would be the side of the face, the patient's face that is fractured appears flattened, loss of sensation over the cheek, nose, and upper lip, and paralysis of an upward gaze. Associated injuries for this in conditions would be orbital fractures, ocular injury, and epistaxis. With dental injuries, fracture of the avulsed teeth are common. This may be associated with a mechanism that causes severe maxillofacial trauma or may occur in isolation. Always assess the patient's mouth following a facial injury. Right, so have them open their mouth up, take a pen light, look inside, or a flashlight, have them stick their tongue out, tongue up, tongue down. Right, look at all the teeth, see if anything is missing. That's from the accident. If the patient has dentures in place and they're well fitting, leave them in place. If they don't, then remove them. So with patient assessment, scene safety, BSI, observe for hazards, take precautions, look for indicators of the MOI, consider how the MOI produced the injuries expected, right? What happened to the scene? What do we expect to see for injury patterns? Does it make sense? Identify life threats. Combative, aggressive behavior can be a sign of a closed head injury. Check for responsiveness, utilizing your AVPU scale, right? Alert, verbal, painful, unresponsive. And suction any blood, fluid, or vomit. Clear the airway, all right? Suction it. Remove any kind of teeth fragments that may be in the airway itself. Consider inserting a properly sized airway adjunct if the patient is unresponsive, whether it be a nasal airway or an oral airway. Remember that nasal pharyngeal airways should not be used in any patient with suspected nasal fractures, right? What would be another indicator of a type of fracture that nasal pharyngeal airways are contraindicated? Where would you find a contraindication? Battle signs, correct, Andre? Battle signs mean what? A fracture to where? Yep, exactly. Basal skull. So assess for adequate breathing and call the paramedic backup because endotracheal intubation may be the method of choice for airway protection. If an airway cannot be established, paramedics may need to perform a surgical airway to ventilate the patient. So we're going to palpate the pulse and rate and quality, determine the skin color and temperature condition, check cap refill, avoid delays in transport, consider paramedic backup, or air transport if the patient is long, transport time is long. We're going to provide rapid transport for any patient who presents with the following. Signs of hypoperfusion, tachycardia, tachypnea, weak pulse, pale, cool, moist skin, and or hypotension, low blood pressure, significant MOI but in stable condition, poor general impression, alteration in level of consciousness, abnormal vital signs, dyspnea, severe pain, and isolated injuries to the eye. Consider transporting patients with serious isolated eye injuries to an eye care specialty center. Let me ask you all this, from the areas that we work in, where is the closest specialty eye center?
Boston.
Yes, Boston. So where in Boston do they need to go?
Mass Ioneer.
Yeah, Mass Ioneer. A lot of times they might get transported right to Mass General and shipped over from there. But if you're going to one hospital to another, like if you were to sample for Huggins Hospital in Wolfboro, they'll probably set up a transfer to go to Mass Ioneer from there. It's kind of like burns, right? What is one of the best pediatric burn centers?
Hasbro, right? That's in Rhode Island.
Children's.
Not Children's. They don't like burns.
Oh, Shriners.
Honest
Yeah,
Shriners, right?
Shriners.
Yeah, Shriners Burn Center, and it's all done by donations. It's a basically a free hospital to go to for kids, right? But you can't transport to Shriners by ambulance. You have to go through another hospital. They have to be admitted and they have to be transferred in. You can't just take a 911 call to Shriners Burn Center. It's kind of like Mass Ioneer. You can't just transport to Mass Ioneer. You have to go through Mass General, and Mass General then sets it up to go to Mass Ioneer for the appointment. I should say the appointment for any kind of surgical intervention that has to be done, right? So there's a process behind it that has to happen, but they need to get to an area that can handle them, right? That's how that's supposed to work, anyways. So history taking. So we're gonna do some more interrogation. So investigate the chief complaint and history of present illness. We're going to obtain a medical history and be alert for injury-specific signs and symptoms. Remember the MOI. If I see something, these should be the injury patterns. Do I see it? Be aware of pertinent negatives, right? Ask the patient questions. Talk to your patient. Obtain a sample history. Attempt to gather from friends or family if the patient is unresponsive. In unresponsive patients, you will only be able to note the signs. You really can't get symptoms, so they can't tell you. Only things that you can see. Then we're going to perform our secondary assessment. If significant trauma is likely affected multiple systems, perform a rapid full body scan looking for decap BTLS. Do not delay any transport. Complete a thorough physical examination. So in order to perform a thorough examination, what do we need to do?
Trauma naked.
Thank you. Trauma naked. We have to expose the patient and do a thorough exam. We need to see exactly what's going on, what we may have missed. Like I said, I've had patients come into the ER before where they have not exposed their patient. I've cut their pants off and found significant, I'm talking 6-inch lacerations with tissue showing because they never looked underneath the pants. Right? You've got to expose your patient. The last thing you want to do is go to an ER and have missed a 6-inch lac. Right? That's not bleeding because you decided not to cut pants off. Right? Let's see. Where was I here? So control any bleeding. Right? Make sure it's maintained and note the injury location. Make sure bleeding is controlled. Tourniquet, hemostatic agents, they work really well. Inspect open wounds for any foreign matter and stabilize any impaled objects that are there. If there's an impaled object, we need to stabilize it. Look for swelling, deformities of the bones, contusions, discoloration, right? You can't really, I mean, you can see deformities, but you really can't feel crepitus unless you actually touch your patient, right? So we have to make sure we're getting personal with them. In our physical examinations, in a responsive patient who has an isolated injury with a limited mechanism of injury, focused physical examinations on the isolated injury, the patient's chief complaint, the body region affected. We're going to assess all underlying systems, neurologic, respiratory, and circulatory. So what can we do to assess a neurologic, or how do we do a neurological assessment? People may want to unmute for this one. There's a lot.
Person, place, time, and event.
Okay, that's one of them. What else?
Pupillary reaction.
Yep, that's good neuro assessment. What else?
DSMs.
Yeah, CSMs. Sensory motor circulation stuff, right? But what else can we do? You guys are throwing a lot of BLS assessment out. What else can we do with the ALS, like more towards ALS for neuro? What about stroke scale? That's a neuro assessment, right? What kind of stroke scale can we utilize? Yeah, Fast CD, Cincinnati, right? There's other ones out there too that you can utilize. NIH, it's a little more in depth. You can also use the LA stroke scale as well. So yeah, a lot of different ones that are out there, right? Have them touch their heel to shin. Have them do the pointer finger to nose. The things feel the same on each side of the face? Start checking cranial nerves. That's our neurological assessment, right? How do we assess respiratory? Lung sounds, end tidal. What else?
Chest rise.
Yeah, chest rise, right? What else are we doing? Pulse oximetry. Ask the patient.
Yeah, I was gonna say the general impression. I mean, if if they're tripod and if they're, having trouble actually speaking full sentences, just a general impression.
Yeah, exactly. Word dyspnea, right, London? That's pretty much what you're trying to tell me. Word
Yeah,
dyspnea.
there you go. That's what I was looking for.
That's it, right? And how do we assess circulatory system? Some of the same stuff, right?
Capillary refill.
Yeah, cap
Skin
refill.
appearance. Skin
Appearance.
appearance.
Extremity pulses, Tandra said. What else? Your ALS providers.
Temperature.
Okay. What else? Circulatory, cardiovascular. EKG, ECG, yeah. 4 lead, 12 lead. Part of circulation, right? Is the heart pumping effectively? Is there something else wrong with it? Right? Don't forget the cardiac monitoring. Right? Start thinking like that ALS provider. ECGs, EKGs. Evaluate the eyes. Examine for any obvious foreign matter. Quickly assess the patient's visual acuity. Right? What's a neuro assessment we can do with visual acuity?
Have them follow your phalange.
Come follow what?
Your finger. He just
Oh, your
used
plan?
the.
Sorry. I didn't hear you. Have them follow your fillet. I like it. That's awesome. Right? Have them follow your finger. What type of pattern do you want to use? Yeah,
Just
exactly, Joe.
slow lateral.
Right. Horizontal lateral. Pretty much H pattern, right? H pattern check. What about checking peripherals? Is that a good neuro assessment? Yeah, absolutely. Absolutely it is. Right? Look for eye symmetry. Each pupil, size, reaction to light. You ever heard of PERLA? PERRLA. Have you ever heard of that before? Anybody?
Yes.
No.
That's pupils equal and reactive and all that to light and all that good stuff, right?
All the good stuff. Pupils equal, round, and reactive to light and accommodation. PERLA. That is more of an ALS assessment. Not just PERL like we used to learn back in EMT school, but that reactive to light and accommodation is the big one, right? Let's see. Determine whether the unequal pupils are caused by physiologic or pathologic issues. You have to ask your patient. You ever had unequal pupils before? You ever had a stroke before? Do you have anoscoria? You have to ask those specific questions, right? Check whether the patient has the ability to follow your finger and read normal prints. You guys have eye charts on your phones or on your iPads in your trucks?
I got an iPhone. We don't got iPads in the truck though.
You got a phone, right? You can download eye charts. They're free. They don't cost anything. Neuro toolkits might cost you a little bit if you bought more of that stuff, right? But have them check that. Can they read? That's a big one, right? If you do the NIH stroke scale, they have to read stuff. They also have to point out different pictures, right? There is a app. I'm looking it up on my phone right now so I can tell you what it is that I use. I just forgot. I just know what it is. I can't remember the name of it. Under medical here. So it's called Neuro Toolkit. Is the actual name of the app for the Apple products, and it has the NIH score in there. It has stroke TIA scales, cognitive scales, epilepsy stuff, neuromuscular, multiple sclerosis stuff, Parkinson's, all a bunch of different references, tools you can utilize. I mean, everything's in there. It's a great app. I use the NIH one all the time on patients to get a good in-depth stroke assessment for patients. So, but it has aphasia pictures as well. Can you see this? The next one here is you have to repeat words on here, like you know how, down to earth, I got home from work, near the table in the dining room. It allows you to actually hear them speak. Do they have any slurred speech? Can they comprehend the words that are there? When they look at the different photos, right? Can they see? Can they address the photo being like a glove, a feather, a key? Do they have that? Are they neurologically in check to be able to tell you that kind of stuff? So those are all very, very important findings. Walk into an ER with all that information with a true NIH scale to a doc, right? They're like, holy crap, they actually know what that means, right? So it's actually pretty interesting stuff. I use the NIH score a lot, especially when I transport any kind of stroke patient, and I monitor the NIH scale even during transfers to see if the stroke is getting any worse. All right, ask the following. Do the facial bones seem to be in alignment? Does the nasal bone seem to deviate from the midline? Is there any facial drooping? Does one eye appear to be lower than the other? Does the mandible appear to deviate toward one side or the other? Use our monitoring devices that we do have. Then do your reassessment. Repeat your primary survey. Again, where'd it go? Recheck patient interventions. Anything that you've done to the patient, you need to reassess. So that's the one, Kenny, that I use. Now you can also download Join Triage is the other one. All right, that gives you that's your fast CD as well. And that's another one for sepsis called the Scavo. And I know that Laurel went over MedMath with you guys. I believe, yes. She went over MedMath with you. Yeah. IV Calc is another app you can utilize for drip infusions and drip rates. For those, those 2 o'clock in the morning. For those 2 o'clock in the morning calls. I'll put one more up there for you. PDStat is absolutely phenomenal app. I don't think it's that expensive at all. It might be, if it's not free, it's like $5, something like that. It's cheap money. And all you do is put in the patient's weight and it gives you or weight or color of the Broslo tape, or I want to say its height as well. Since we're on apps really quick, that's what I'm going to tell you. Age, weight, Broslo tape, or length, the height of the patient. And it gives you all you'll need to know on dosaging for everything you're going to give for that specific weight or height. Called PD stat. Great for med calc stuff if you don't want to do all the math for pediatrics. All right. Reassess condition at least every 5 minutes. Recheck your interventions that you've done. And then communicate and document. Description of the MOI, position you found the patient. Motor vehicle accidents, take pictures. Show them to the doctors, attach those photos to your own report. Right? And then delete them off your phone after because it could be HIPAA. Get pictures without license plates. Right? If you're using it for documentation purposes, there's nothing wrong with taking the photo. If you're going to post it on Facebook, that's an issue. Document the method used to remove the patient from the vehicle, how you did it. Estimate and report the amount of blood loss that has occurred and how rapidly or how much time has passed since the bleeding started. Call early to inform the hospital. Give them trauma alerts. And please do not do it 3 minutes out. Give them time to start preparing. All right. So emergency care for this would be provide complete stable spinal mobilization to any patient with suspected spinal injuries. Maintain an open airway, OPA, NPA, whatever is needed, King tubes. Provide high flow oxygen for patients that need high flow oxygen. Control significant visible bleeding. Remember, bleeding requires high flow too. Right? Remember, losing oxygen, red blood cells. Control significant visible bleeding. If the patient has signs of hypoperfusion, aggressively treat for shock and transport promptly. Call for paramedic care for these. If you suspect internal bleeding, call for medics because we have something called TXA, tranexamic acid, that we can administer to a patient. Right? Like I said, I mentioned probably in another class before, I gave TXA to a kid and it saved his life because he had a significant internal bleed in the pelvis that wasn't being picked up on any other way. Do not delay transport to a seriously injured patient, trauma patient, to complete a non-life-saving treatment in the field. Right? We can delay transport to treat serious injuries, but if it's non-life-saving, start getting them to the hospital. Gain IV access with 1 or 2 large bore catheters. Okay, 20 gauges do work. 18s are better. Please do not be the hero and do 14 gauges. It's very mean. Right? 20 ml per kilo bolus of isotonic crystalloid solutions and maintain radial pulses as signs and symptoms of hypoperfusion are apparent. Right? New Hampshire protocol stuff. Lactated ringers is great for trauma patients. So, really quick, someone needs to give me an answer here. Right? You have a 300-pound male patient. You're going to give them 30 mLs per kilo. All right, that's our dose for New Hampshire protocol. 30 mLs per kilo of a fluid bolus at 300 pounds. Well, how much fluid are we going to be giving them? Yep, pretty close. Yep, perfect. That's 4 liters of fluid if you do 30 mLs per kilo. Now, every 250 to 500 mLs, we got to reassess what?
Lung sounds.
Lung sounds. Exactly. Good. All right, so the soft tissue injuries, which we're going to be covering more in depth on the next chapter anyways. This is more for facial. Focus on protecting the airway. Bleeding can include an airway. Bleeding can cause vomiting, which then can include airway even more. Assess ABCDEs and care for any life threats. Take standard precautions. Open and clear the airway in the absence of life-threatening bleeding. Secure and maintain a patent airway. Take appropriate precautions for suspected cervical spine injuries. We're going to use a jaw thrust maneuver to open the patient's airway and then suction the mouth. How long can we suction for?
Or is it 10 to 15 seconds?
Yeah, I need a good.
Oh,
Need a book.
oh.
The book answer is no more than 10 to 15 seconds, right? Real world, we suction to get the blood out of the airway. Control any external bleeding with any direct manual pressure. Traumatic patients get jaw thrust maneuver. We're going to cover the exposed parts with a moist, sterile dressing and treat facial lacerations and avulsions as any other soft tissue injury. All right, we're going to treat them the same and check for bleeding inside the mouth. We're going to wrap the portions of avulsed skin that have become separated in a sterile dressing, moistened. Right, we don't want it to pull off. We might be able to reattach it. The saline in place as well. Place them in a plastic bag or in a cool temperature. Never place tissue directly on ice. It will kill the nerve endings and everything else. They'll be unable to reattach. Deliver the bag labeled with the patient's name to the ED along with the patient. If the skin is attached in a loose flap, take it, put it back in the right position, and cover it up. Injuries to the eyes. So proper emergency medical treatment will minimize pain and help prevent a permanent loss of vision. Right? Depending on the type of eye injury, paramedics have something called tetracaine. Right? They also have Morgan lens kits to be able to flush out eyes. What's another method we can utilize to flush eyes out if we need to?
Open a saline bag, let it drip over the patient's eyes.
Yep. Another way to do that, though, like Matt O'Connor just said, nasal cannula. Right? Pressure bag, 15 drop set, hook the end of it into a nasal cannula, and put the nasal cannula between the eyes, let it flush out. Good way to try that. We can mess around with those too, a little bit. Pupils are round, usually equal in size, and react equally to when exposed to light. Both eyes should move together at the same time in the same direction when following your finger. If they go in separate directions, we've got a problem. After an injury, pupil reaction, shape, and eye movement are often disturbed. So normal pupil reactions sometimes are a sign of brain injury rather than just an eye injury itself. All right, so look for specific abnormalities or conditions that may suggest the nature of the injury. Look for foreign objects. The conjunctiva becomes inflamed and red, which would be conjunctivitis. And the eye begins to produce tears in an attempt to flush out the object itself. Irritation of the cornea and the conjunctiva cause intense pain and aggravated by bright light. So many patients may have difficulty keeping their eyelids open. With that being said, we may have to force the eye open as well. Irrigation of a sterile saline solution will frequently flush away loose, small particles. So use a bulb syringe if available, or a nasal airway, or a cannula to direct saline into the affected eye. Always flush from the nose side down, right? So we don't want to have the infected eye being up high and flushing it into the good eye. Right? Foreign bodies will leave small abrasions on the surface of the conjunctiva, which can cause significant pain. Right? If that's the case, again, paramedics have tetracaine that they can administer. 2 eye drops to help reduce the pain and numb it up. Gentle irritation usually will not wash out foreign bodies. Gentle irrigation, sorry, to the cornea or lying under the upper eyelid. So again, you might need a Morgan lens kit. So to examine the undersurface of the eyelid, pull the eyelid upward and forward. If you spot a foreign object in there as well, try removing it with a moist, sterile, cotton-tipped dressing or some type applicator, as illustrated in Skill Drill 29-1 in your book. Never attempt to remove an object that is stuck in the cornea. Foreign bodies may be implemented in the eye as well. I've had patients that have had taser probes right through the eye before. Cover it up, transport them to a hospital so they can go to get it removed. These have to be removed by a physician. We do not start pulling things out of people's eyes. Stabilize the object and prepare for patient transport. as well. So the greater the length of the foreign object sticking out, the more important stabilization becomes. So we got to make sure we put, I've used cups over them before. I've used a bunch of different things to cover the eye. And remember that when you do that, you want to cover the other eye as well, right? So they'll be dark in one eye and covered up in the other with the stabilization technique you use. We're going to make sure we bandage both eyes, like I mentioned before, to prevent any further injury to the affected eye, because if one eye moves, the other one's supposed to go with it, right? So we got to kind of make them blind for a while in the dark. An embedded object in the eye must be handled by an ophthalmologist on an urgent basis. Hospitals don't normally have ophthalmologists there. So burns of the eyes, we're going to stop the burn to prevent further damage. Chemical burns usually caused by acid or alkaline solutions. We're going to flush the eye with clean water and a sterile saline irrigation for at least 5 minutes. Ideally, you will use a bulb or irrigation syringe or a nasal cannula or other device that will allow you to control the flow. So if you look in the picture on the left-hand side, you're utilizing a nasal cannula to flush out both eyes. If not available, pour water into the eye by holding the patient's head under a gently running faucet. If only one eye is affected, take care to avoid getting contaminated water in the unaffected eye. Irrigate for at least 5 minutes. We're going to flush from the inner corner of the affected eye outward to the outer corner. If the burn was caused by an alkali or a strong acid, irrigate the eye continuously for 20 minutes. All right, after completing the irrigation, apply a clean, dry, sterile dressing over the eye and transport. If irrigation can be carried out in the ambulance, it should be done during the transport itself. If you're going to do this in the back of the ambulance and they're laying flat on their back, take a lot of towels and put them underneath the patient because they're going to get soaked, right, during the transport. So these are chemical burns to the eyes, as you can see in these figures here. Right, these are thermal burns. Burning of the eyelids requires very specialized care. Not many hospitals can handle this. Provide prompt transport of these patients without further examination. Cover both eyes with sterile dressing moistened with sterile saline. You may apply eye shields over the dressings as well to kind of hold them in place. Infrared rays, eclipse light, laser burns can all cause significant damage. Retinal injuries caused by exposure to extremely bright light are generally not painful, but may result in permanent damage. Superficial burns of the eyes can result from ultraviolet rays, from an arc welding unit, light from prolonged exposure to a sun lamp, or reflected light from a bright snow-covered area as well. Burns is not too painful, but may become so in 3 to 5 hours later, but the initial burn might not be painful at all. Severe conjunctivitis usually develops with redness, swelling, and excessive tear production. Remember that conjunctivitis is also very contagious. Cover each eye with a sterile, moist pad and eye shield as well. Have the patient lie down during transport and protect him or her from further exposure to bright lights. All right, so lacerations require very careful repair to restore appearance and function. If there is a laceration of the globe itself, apply no pressure to the eye. Treatment guidelines would be never exert pressure or manipulate the injured eye in any way. If a patient's eyeball is exposed, we want to gently apply a moist sterile dressing to prevent drying out. Cover the injured eye with a protected metal shield or cup or sterile dressing. Cover the other eye to minimize movement. If the eyeball is displaced from its socket, do not attempt to manipulate or reposition it back in, right? Don't push it back inside. Cover both eyes to prevent any further injury and have the patient lie supine to prevent loss of fluid from the eye itself. As far as blunt trauma goes, injuries range from ordinary black eye to severely damaged globe. So hyphema, which is bleeding to the anterior chamber of the eye, obscures all or part of the iris. Complete So this is very common in blunt trauma, where you want to cover the eye, protect from further injury and transport. All right. This will cause potential of a rupture of the globe, which may signal the presence of a spinal injury. So elevate the head of the backboard approximately to 40-degree angle and decrease the interocular pressure, IOP. So we're going to discourage the patient from performing activities that may increase IOP, like coughing, vomiting, anything that increases that ocular pressure, we want to reduce. So patients that have this, that become nausea, that are nauseated, give them Zofran. Right, reduce that nausea, prevent any vomiting from happening, try to make sure they're not coughing. Anything that increases ocular pressure can cause more significant damage. An orbital fracture or a blowout fracture, they call, typically a fracture of bones from the eye floor and support the globe. So place the patient on a stretcher and transport properly to the ED. Protect the eye with a metal shield and cover up the other eye to prevent movement. Retinal detachment, the separation of the inner layers of the retina from the underlying choroid, often seen in sports, especially boxing. This is painless but produces flashing lights, specks, or floaters in the field of vision and a cloud or shade over the patient's vision itself. This requires urgent medical attention to preserve any kind of vision. The possibility of a head injury, if you see eye injuries with the following head trauma, where one pupil is larger than the other. Remember that this could also be anoscoria, so ask the patient about their history. Eyes do not move together or they point in different directions. It's called a disconjunctive gaze. So eyes that fail to follow movement or your finger as instructed. Bleeding under the conjunctiva, which obscures the sclera. Protrusion or bulging of one eye. For an unresponsive patient, you want to keep the eyelids closed. Cover them with a moist gauze or hold them closed with a clear tape. So you can put tape over their eyes and keep them closed. Patients that are unresponsive, they get intubated. Usually we will do that. We'll tape their eyes closed. Blast injuries, as far as management and the severity of it basically depends on the severity of the injury. If a foreign body is embedded in the globe, do not attempt to pull it out. Right? Use a clean cup or similar item to protect the area. And if only one eye is injured, follow local protocol. If the patient has a severe swelling or hematoma to the eyelid, do not attempt to force the eyelid open to examine the eye. And that'll cause more significant damage. Contact lenses are artificial eyes. So never attempt to remove a lens from an eye that may have been injured. Leave the lens in place. The only time a contact lens should be removed immediately in the field is in the case of a chemical burn of the eye, so it doesn't attach to the eye itself. So to remove a hard contact lens, use a small suction cup, moistening the end with a saline. Soft lens, place 2 drops of saline in the eye. Gently pinch the lenses between your gloved thumb and index finger, and lift out on the surface of the eye and pull it out. Inform the ED if the patient is wearing contact lenses as well. They need to know. So nosebleeds, a lot of this stuff is pretty much a review for you guys. Nosebleeds or epistaxis are very common. So what are some common things that could cause nosebleeds? So hypertension, digital trauma. What else we got? Dry air. Yep, wood stoves. Right. Some of the big ones that can be concerned about, though, is going to be your hypertension. That's a concerning one. The rest of them we can deal with, but hypertension, though, high blood pressures, right? Vessels are starting to break due to the increased pressure at rest and in movement. So it's classified into anterior and posterior based on the bleeding area. The anterior nosebleeds usually originate from the area of the septum and bleed fairly slowly, usually self-limiting and resolve pretty quickly. Posterior nosebleeds are usually more severe and often cause blood to drain down the patient's throat. A basilar skull fracture caused by trauma to the face and skull often cause the posterior wall of the nasal cavity to become unstable. So blunt injuries to the nose caused by a fist or a dashboard may be associated with fractures of soft tissue injuries of the face, head, neck, and spine. So assess all structures of the nose for injury. Patients with severe injury may have injuries to the cervical spine as well. So see caller of the patient. If there is trauma, and look for cerebrospinal fluid, which may escape down through the nose and ears following a fracture of the head of the skull, or at the base of the skull, I should say. So this figure here shows two different chambers of the nose divided by a septum, as you can see here, septum being down the middle. These are different turbinates, superior, middle, and inferior movement. So epitaxis. I think we're losing Sean for a minute there. All right. So following that, control bleeding from abrasions and lacerations by applying a sterile dressing. Assess the patient's signs for hemorrhagic shock and administer crystalloid fluids as bolus immediately or shock-like symptoms. What are some other things we can do to stop nosebleeds? Yeah, nose clips and ice. Exactly. Cold packs over the bridge of the nose. I've seen it done on the back of the neck before too, but usually the bridge of the nose works pretty well. It helps it clot. And Sean keeps losing connection and coming back. All right, so injuries to the ear. Isolated ear injuries can result in a sensory impairment and permanent disfigurement. So they do not usually bleed very much. If local pressure does not control bleeding, apply a roller dressing. First, place a soft padded dressing between the back of the ears and the scalp. Bandaging the ear against the scalp can be extremely painful. If blood or CSF drainage is noted, then apply a loose dressing over the ear itself. All right. If the pinna is partially avulsed, carefully realign the ear into position. Gently bandage it with a sufficient padding that has been slightly moistened with normal saline. Attempt to retrieve the avulsed part of the ear for re-implementation. If the detached part of the ear is recovered, then treat it like any other amputation. Remember, wrap it up, put it on ice. Never place an amputated part directly on ice. It needs to be wrapped first, right? And do not remove an implanted object in the ear. If it's in the ear, it stays. So all foreign bodies should be removed by a physician in the ED. Do not manipulate the foreign body. The signs and symptoms of a perforated tympanic membrane include loss of hearing and blood drainage from the ear. So the other name would be hemorrhagic otorrhea. This is the name for the blood drainage. All right, so facial fractures. I'm just going to finish up this chapter, guys, and we'll take a 10 or 15-minute break and start the next one. We're getting close to the end. So if the patient sustained a direct blow to the mouth or nose, then maintain a high index of suspicion for facial fractures. Other clues would be bleeding from the mouth, inability to swallow or talk, absent or loose teeth, or a loose or immovable bone fragment.
There are no timers.
I didn't say anything about a timer. All right, so other facial fractures alone are not acute emergencies unless they are serious bleeding. Indications of significant blunt force trauma. Serious bleeding can be life-threatening. So blood clots may also become lodged in the upper airway and cause an obstruction as well. So fractures around the face, mouth can also produce deformity and loose bone fragments. Plastic surgeons can repair the face and the mouth if injuries are treated within 7 to 10 days. To remove and save a avulsed teeth or free bone fragments from the mouth, because it is often possible to put them back in and have them replanted. Remove any loose dentures or dental bridges to protect against any kind of airway obstruction. Another source of potential airway obstruction is swelling. Right, so this can be extreme for the first 24 hours after the injury. So you want to check for airway obstruction if you notice it. For oral and dental injuries, blunt mechanisms typically result in motor vehicle accidents or blows directly to the mouth or chin, where penetrating mechanisms include gunshot wounds, lacerations, and punctures. The primary risk is airway compromise from oropharyngeal bleeding, occlusion of a displaced dental appliance, and possible aspiration of an avulsed or fractured tooth or teeth. Suction of the oropharynx as needed and remove fractured tooth fragments. Apply spinal mobilization as directed by the MOI. Apply direct pressure to stop the bleed. For severe oropharyngeal bleeding in patients with inadequate ventilation, suction the airway for 15 seconds and provide ventilatory assistance for 2 minutes. All right, if there's an impaled object in the face, and leave it in place and then appropriately stabilize them. Unless they pose a threat to the airway, then it can be removed. Pack the inside of the patient's cheek with sterile gauze and apply counter pressure with a dressing and bandage firmly secured over the outside of the wound. When dealing with an avulsed tooth, handle it by its crown only and not by the root. Do not allow the tooth to dry. Notify the receiving facility about the avulsed tooth. What can we put teeth into to help preserve it?
Milk.
Milk. Yep. Exactly. So injuries to the neck. Any injury to the neck is serious and should be considered life-threatening. So blunt injuries, obviously any crushing injury to the upper airway, upper part of the neck is likely to involve the larynx or trachea, which is why you need to palpate it and make sure you don't feel any crepitus, make sure it's all in line. Once the cartilages of the upper airway and larynx are fractured, they do not spring back to the normal position. They stay fractured. They can lead to loss of voice, difficulty swallowing, severe and sometimes fatal airway obstruction, leakage of air into the soft tissues of the neck. Right? If we have leakage of air, what is that called? In the tissues. What's another name for that? Right here on the screen. Yep, there you go. Subcutaneous emphysema, like Rice Krispies, is a characteristic crackling sensation produced by the presence of air in the soft tissue of the neck. If you feel this when palpating the neck, maintain the airway as best you possibly can and transport immediately. Right? Complete airway obstruction can develop very rapidly if the airway is very difficult to manage. Consider paramedic support. Some patients will require surgical airway at the hospital as well. An incident involving an injury to the throat may also cause a cervical spine injury. So spinal mobilization may be needed for these. As far as penetrating injuries to the neck, primary threats are massive hemorrhage, right? Carotids, right? Internal, external, jugular. Compromised by swelling or direct damage to the larynx or trachea. So penetrating injuries can cause profuse bleeding from the laceration of the carotid arteries or jugular veins. Injuries of the carotid and jugular vessels in the neck can cause the body to bleed out and quickly. So a possibility of a fatal air embolism may also be present. So a large amount of air entered into the right atrium and the right ventricle of the heart can lead to cardiac arrest. Immediately seal an open neck wound with an occlusive dressing and avoid constricting the vessels and the structures of the neck. Right? So be alert for swelling and expanding hematomas. So follow the steps in 29-3 in your book. Or to apply pressure above and below the penetrating wound to control life-threatening bleeding. If do not remove impaled objects. Remember, if indicated, maintain cervical mobilization. Provide prompt transport, and en route, ensure the airway stays open. Constantly renew the airway. Review it. Assess it. Administer high flow oxygen and obtain vascular access. Put these patients on a cardiac monitor. With laryngeal injuries, when the larynx becomes crushed against the cervical spine, a soft tissue injury, fracture, or a separation from the fascia can result. So open injuries to the larynx can occur as a result of a stabbing or other penetration. Penetrating or implanted objects in the larynx should not be removed unless they interfere with a cardiopulmonary resuscitation. So if they're in the way for CPR, pull them. Right? Penetrating or objects impaled in the larynx should not be removed. Remember that. Stabilization or stabilize of all impaled objects if they are not obstructing an airway. Right? And maintain a high index of suspicion and perform a careful assessment of any patient with blunt trauma to the anterior part of the neck. Signs and symptoms of a larynx injury would be respiratory distress, hoarseness, pain, dysphagia, hemoptysis, cyanosis, pale skin, sputum in the wound, subcutaneous emphysema, bruising of the neck, structural integrity, hematoma, and bleeding. Right. Esophageal perforation can result in a mediastinitis. If the larynx is injured, the incidence of cervical spine injury is high. Right. So the patient should avoid shaking his head. To manage a laryngeal and tracheal injury, provide oxygenation and ventilation, apply a cervical collar, avoid the rigid collars, be alert for the need for frequent suctioning, do not delay transport, and call for paramedic backup for advanced airway management, especially if the patient is apneic. All right, to finish up this chapter here, muscular injuries are the most non-penetrating injuries that are classified as sprains and strains. Remember that a strain is a stretching or a tearing of a ligament where the muscles contract as they attempt to support the neck. Maintain a high index of suspicion for cervical involvement and provide cervical spinal stabilization. A strain is a stretching or tearing of a muscle or tendon, and the most common form of cervical strain is often called whiplash. So recommended for transport to patients to ED for radiologic studies to see if there's any kind of fractures. So we're going to conduct a visual inspection for signs of soft tissue injury. If you are to suspect a musculoskeletal injury to the neck, address any airway, ventilation, and oxygenation consideration, and ensure no major circulatory compromise is present. We're going to focus on preventing further injury by restricting range of motion. We're going to check distal pulses and sensory motor functions before and after a full body splint is applied. All right. Patients reporting neck pain should be evaluated for injuries and prevention for long-term consequences. So to finish up, helmets, face shields, mouth guards, and safety eyewear help prevent injury. Better occupant safety restraints and airbags have come out to help prevent contact with the interior of the vehicle. As you know now, there's a ton of different airbags in every vehicle now that's coming out. So improvements to the headrest reduce the number of neck strains as well. They've had some improvement of headrest. They manipulate, they move differently now with that. All right. So let's come back at 7:30. All right, we'll come back at 7:30 and we'll finish up.
This conference will now be recorded.
All right, so we're going to cover chapter 28, soft tissue injuries. All right, so obviously with the skin, okay, being one of our body systems, is the largest organ of the body, also plays the first line of defense against external forces and infection. But because of this, it makes it susceptible to various injuries. So soft tissue injuries may result in exposed or deep structures as well. So dressing and bandages would be utilized for controlling bleeding, preventing further contamination, and protecting the wound from any kind of further damage. So the mechanism of injury obviously would be blunt or penetrating or burns for trauma. Death from soft tissue injury is often related to hemorrhage and or infection. So protective actions are necessary to prevent injuries. So we utilize gloves, workplace safety measures, teaching children to avoid or request help when using sharp objects. We try to find ways for prevention for this. So a little bit about A&P, kind of a quick review. The skin varies in thickness, right? We have two principal layers, the dermis and epidermis. Excuse me, epidermis and dermis. We go the right direction here. The epidermis is the tough external layer that forms a watertight covering, where the dermis is the inner layer of the skin that lies below the epidermis, containing the hair follicles, sweat glands, sebaceous glands, blood vessels, and the dermis also provides the skin with nutrients and oxygen, right? The orifices in the body are lined with mucous membranes. The skin functions protect the body, they have sensation, and they regulate temperature. As you can see, looking at this slide here, that you can write down through, from the sebaceous gland to the erector pili muscle. The erector pili muscle is utilized to stand the hair up on end. As you can see, it starts with the dermis, going to the epidermis, into the subcutaneous, that fatty-like tissue, which then also includes the fascia, which then goes into the muscle, right? So we can determine our degree of burn based on how far into the skin it gets, into the bone as well. So this is why our skin is so highly vascular, is because we have so many different blood vessels, as you can see coming through here, going to the top layer of the skin to oxygenate and meet perfusion status. So if we have a laceration, it gets into the capillary beds over here, and we have different types of bleeds. Remember, there's three different types, right? There's arterial, venous, and capillary. So the skin tension lines, our skin is arranged to provide tension. So static tension develops over the areas that have limited movement. So lacerations occurring parallel to the tension lines may remain closed with little or no intervention, where a dynamic tension found in areas that lie over the muscle. So open injuries to dynamic tension lines interfere with healing because they disrupt the clotting process in the tissue repair cycle. So a little bit about pathophysiology of the closed and open injury. So a soft tissue or soft tissues are often injured when exposed to the environment, right? So again, types of would be burns, open or closed injury. Closed injuries are characterized by a history of blunt trauma and pain at the site of the injury, swelling beneath the skin and discoloration. A contusion causes bleeding beneath the skin but does not break it. So remember, we have the closed contusions, right? Well, 1 second here. All right. So ecchymosis is blue or black discoloration. A hematoma is a pool of blood collected within the damaged tissue or the body cavity, and crushing injury occurs when substantial force is applied to the body itself. All right. So looking at the picture here, what would you guys call this?
Hematoma?
Okay, I see a hematoma. What else do you see on there?
The hematoma and ecchymosis.
Right. So we're seeing, if you want to break it down, we have hematoma, ecchymosis. I see some bleeding, right? there. It's probably a laceration or a skin tear underneath that. You see the hematoma. Can you guys see the mouse on the screen that I'm doing this?
No.
No? Hold on a minute.
Yeah.
Here I am like
No.
trying to design, like draw things on here, and you guys can't see any of it. Let me do this. Can you see the laser pointer?
Yes.
Perfect. You can see something I'm doing here. I like it. All right. So kind of looking at it closely, as close as I can see it. Right. So you guys are right. The hematoma located up here. It looks like there's an avulsion or a laceration through here. Right. And you can see the kind of blood kind of drips down the chin. Not chin, the cheek, I mean. Sorry. But do you see some bruising here around the eye? So could that have caused an orbital fracture? Maybe. Possibility. Right. So we got to push and assess around the eye itself. We also want to make sure there's no vision issues as well. The blood internally could be leaking down through to above the eye, which is going to cause significant swelling. Right. And if they're on blood thinners, it's going to make it even worse. So with closed injuries, we have crush syndrome. So tissue necrosis develops as a result in a release of harmful products into the bloodstream when the limb is freed from entrapment. Renal failure may develop as the kidneys attempt to filter out the harmful products associated with the degradation of the dead muscle tissue. Compartment syndrome is characterized by pain that is out of proportion to the injury. So what's so significant about crush injury? What is it releasing? What harmful toxins does it release? Right, lactic acid. Right, yeah, lactic acid buildup, perfect. So what happens if we take a heavy object that's been crushing them and we lift it up rapidly?
It'll flood the body with lactic acid.
Yeah, it'll kill somebody, right? So what do we have to do? Suddenly flood, right? So what do we need to do for these patients? Everybody should have the same quick answer, right? Fluid. What else? Right? We need medicine. Right? Medics. So Justin says needs bicarb bolus. So one of the biggest issues with crush injuries, okay, is the fact that we have a crap ton of potassium still in the cell. And we have to find a way to move this potassium out of the cells. And there's four medications that can be administered by a paramedic to assist with this. All right, that helps move that potassium. And while doing it, we need to be running EKGs, right? And we're only lifting a little by little, enough not to kill our patient. There's 4 meds. One is sodium bicarb, which Justin put down. Any of you guys know the other 3? I just out of curiosity. You ever heard of them? No. So another one would be calcium chloride, calcium gluconate. And the last one is albuterol. Now, it's not just a simple neb. It's 20 milligrams of albuterol. And that's within New Hampshire scope of practice for medics. But to kind of have an idea of what has to be done, what has to be given in order to save this person's life. So if you respond to a scene as an A, get your IVs established. They're going to need plenty of pain management. So get IVs in, get cardiac monitors on, call for paramedic care so we can start administering these other life-saving medications to get this object off the patient, right? So that's the compartment syndrome, the crush injury stuff with tissue necrosis. We don't want that lactic acid to build up and then be delivered in a high abundance of potassium. What would happen to the patient's heart if an abundance of potassium got pushed into it all at once?
It would stop.
Yeah, eventually it would stop. Right, exactly. Right, lethal rhythms, we'll call it. Right, so some other pathophysiology of the open and closed. Obviously, open can produce extensive bleeding, contamination. obviously with presence of infected organisms or foreign bodies. Abrasions caused when the body parts rub and scrapes across a rough, hard surface, so road rash, things like that. Blood may also ooze from the injured capillaries and the dermis as well. As you can see in the photo here, where my highlighted is, you're going to notice that this area is kind of shaved down. So we're going to have a lot of capillary bleed. Or here you can see a road rash or burning sensation as well. All right. So a laceration being a smooth or jagged cut caused by a sharp object or a blunt force trauma that tears tissue. So the depth of the injury can definitely vary with that. It may appear linear or as you can see here. So this direction, multiple different lacerations, you can see. I'm using red over blood. This is a horrible idea. We use green. That's how it'll work. All right. As well. So an avulsion separates the various soft layers of the tissue so they can hang as a flap. So as you can see with the flap located here, this is fun using this stuff. We have the avulsion located here as well. We want to take the skin, so I'm going to highlight the flap of skin here, and kind of try to find a way to fold that back and then wrap it back over the top, and kind of an avulsed. If it's an amputation, that's a completely avulsed body part. Obviously, amputated parts need to be put onto ice, obviously wrapped, and then transported, even with the skin layers as well. They might be able to actually reimplant that back. Animal bites, consider all animal bites contaminated and potentially infectious. We do not, if we have animal bites to like the hands, as you can see here, and this is the top of a hand, we do not want to wrap these things tight. Why is that? Even human bites, anything that would have potential infection. Dog bites are the worst. Why don't we wrap a hand tight to control bleeding with those?
Will you bring it to a point where you get? Oh yeah, I was gonna say. Somebody saying smell. I was gonna say you bring it to a point where all the whatever toxins or whatever will cause the infection to basically pull into one spot and swell the hand up or make it worse.
Exactly. So the more swelling it gets and the tighter your bandage, cuts off circulation, right? So we need to allow that to expand. They're going to need a significant antibiotic, IV antibiotics, things like that to kind of control all that and to kill the infection that's in there. Or they may have to actually cut it open to allow that swelling to continue, right? So there's potential that's there for that. As you can see, human bite, same thing. If a human bite punctures the skin, as you can see right here, right, that's significant because there's a lot of infection, right? Even we go as far as penetrating wounds, right? We don't pull these out, we leave them in place, we stabilize them and bring them to the hospital. So open wounds as well. Open abdominal wounds may also expose internal organs, as you can see up here and down below, right? If we have an evisceration of some sort of this, right here, what we don't want to do is pack those back in, leave them exposed. We want to cover them with a moist, sterile dressing. And this will allow it to not dry itself out. So when they go to the OR, they can be put back into your proper places, right? Any avulsion to the neck or open neck injuries can be considered life-threatening. And these here need to be covered the best we possibly can, especially if it's just a laceration to the neck. We mentioned before, we don't allow air embolus. If we allow air emboluses to get in, it gets into the skin. What would that be called again? What's the name of that? The air bubbles underneath. Please don't call them Rice Krispies. What is that called again? Hi, Jen. Welcome back from your transfer. Yeah, subcutaneous emphysema.
Subcutaneous emphysema. Yeah.
Perfect. All right, stand by 1 second. I gotta plug my computer in. I thought I could make it through the lecture before it died. Obviously not. So they have like 5% battery. I don't want to kill it. That would not be good. All right, we got power. Perfect. So open crushing injuries may involve damage to internal organs or broken bones. As you can see here, significant crush, a lot of damage to that area right there as well. You can see where the significant swelling is, and some more fractures located in here. Blast injuries also result in multiple penetrating injuries as well. Remember the shrapnel coming through. So as far as wound healing goes, infection, where this increases with size and depth of the penetration. So you may have some bacteria. Account for most bacterial skin infections. Visible clues would be erythema, pus, warmth, edema, local discomfort. You also got to look for signs of sepsis as well. Dead tissue like gangrene caused when blood supply to the tissue is interrupted or stopped completely. Diabetes, arteriosclerotic peripheral vascular disease may also cause this as well. This may also be caused by traumatic injuries. It may have a bad odor. These signs would be discoloration of the limb to black and blue, red, or red. If not treated, it can become necrotic and result in sepsis. Tetanus is caused by an infection. Bacterium then produces a toxin, resulting in painful muscle contractions that are strong enough to fracture bones. This is a rare occurrence because of the vaccine that's out there, the tetanus shot or Tdap. Muscle stiffness may not be noted first, or maybe noted first in the jaw and neck, with progression down to the remainder of the body. So how can we have the potential to obtain tetanus? How can we get that infection?
Rusted pieces of metal, things like that.
Yeah, exactly. And how often should someone get a tetanus shot? When do they get them?
Every 5 years.
10 years.
Yeah, so every 10 years.
10 years.
Okay, or after an
Or if
exposure.
you have a new exposure.
Yep, new exposures receive tetanus as well. Necrotizing fasciitis. Most serious form of necrotizing fasciitis, inflammation of the fascia. Involves death of the tissue from bacterial infection caused by various infecting organisms, but most often group A, Streptococcus. So we're going to look for a history of vector transmission, insect bites, puncture wounds, things like that. Symptoms would be redness and warm skin, fever, night sweats, chills, vomiting, and diarrhea. What were they, for a while, this was actually more popular in the Manchester area years ago. What were they injecting heroin with, mixing it with? That was causing this necrotizing fasciitis.
Was it fentanyl?
Not fentanyl.
Ether?
It was
That
called
was like
crocodile.
embalming fluid, was it?
Yeah, remember the crocodile that was out for a while?
Yeah.
They were injecting. It's like a petroleum product. They were injecting into their veins to get high. That's crazy. But necrotizing fasciitis. Now, can we administer something at the AEMT level that can become very necrotic? All right, Kenny, I'll talk to you later.
E50.
Yeah, the D10 or D20 or D25,
Yeah.
D50, whatever it is. Yeah.
Yeah,
The
anyone
D50.
extra.
D50, D10, D25, anything with a higher concentration of the sugar, right? any one of those can cause necrotic tissue. That's why it's so important to make sure you have a decent vein. So as part of the assessment for the closed, physician should always evaluate certain wounds, right? So assessing closed injuries is more difficult than assessing open ones. So consider substantial underlying injuries in case of bruising, swelling, deformity, or pain. So scene size up would be address the hazards, obviously determine the number of patients, the whole deal, right? I don't think I need to keep repeating myself on our initial scene size up, right? Diligently search for ejected patients in the case of a substantial vehicle crash, especially with rollovers, right? Always maintain a high index of suspicion. Primary survey. Do not let soft tissue injuries distract you from life threats that may not be readily apparent. We have injuries, significant arm fractures, right? So if you have a humerus fracture, let's say ulnar radius fracture, is that considered a significant injury? Okay. Open
I would say
fracture.
no.
No, not really, right? And compared to a femur fracture, a pelvic fracture, where things that we can't see, like a pelvic fracture, you're not going to bleed out with a closed arm fracture. It's not going to happen. You're going to bleed out from an open book pelvic fracture with lacerated arteries, right? So don't let the grossness or the coolness of the wound, however you want to look at it, right, and say, wow, this is pretty bad, but we're missing the critical stuff, right? That's what your rapid trauma assessment is designed for, to find and identify life-threatening injuries and treat them right away, and then go back and manage your secondary injuries afterwards. That's why it was invented, right? So rapidly determine whether threats are life using the XABCDE mnemonic, control substantial bleeding, perform manual inline stabilization of the C-spine, check for responsiveness using the APU scale, breathing, circulatory status, and do they need immediate transport or stabilization on scene? Do we need air medical? Do we need paramedics? Do we need ground transport? What do we need to do? We're going to gather information, determining the MOI, sample, OPQRSTI, and higher priority patients should be given to the patients taking warfarin or other anticoagulants. We have to remember to ask our patients if they're taking anticoagulants of any form. And they may say, well, I'm not sure what the anticoagulants are. Blood thinners, warfarin, Coumadin, Xarelto. Start throwing all the different names that are out there that you can remember, right? Most of the more common ones. The secondary assessment reveals injuries or medical conditions missed during the primary survey. Okay, secondary assessment will pick up and will treat the non-life-threatening injuries. Reassessment of vital signs and soft tissues, remember the injuries can cause shock, so we want to make sure we're using our monitoring devices, right? Tachypnea, tachycardia, monitoring end titles so we can monitor respiratory drive, right? Perfusion, oxygenation. There's so many things we have to utilize for these patients, and at the AEMT level, we have a lot of this stuff at our disposal, right? So treat your patient. Reassessment should be made en route to the hospital, not on scene. Take and evaluate additional sets of vital signs, check interventions, make sure things are working that you've done. If you're doing fluid boluses, then do fluid boluses, okay? And then monitor vital signs every 5 minutes. Are you trying to have you achieved the goal you're looking for fluid? Have you achieved the goal for pain management? Right? Ice is still pain management. Control it. You'd be surprised how much ice can do for a patient, right? Or even just giving them PO Tylenol if they can drink, if they're allowed to, if they're not going to be NPO, right? Assess all bandaging frequently, right? Doesn't mean if you put bandages on a patient, doesn't mean that it's going to stop the bleed. It may just slow it down. So you may have to reassess and put more bandaging on place. Describe the MOI, position you found the patient, and also an estimation of how much blood loss there was in the ground. Provide accurate account of treatments. For closed injuries, extensive injuries could result in hypovolemic shock and could be life-threatening, or can also damage internal organs. Remember to assess and manage all threats to ABCs. Treat by using RICE or RICEs, rest, ice, compression, elevate, splint. We can do this in the back of the ambulance. We can elevate, we can splint, we can put compression on, right? So extremities that are painful, swollen, or deformed should be splinted. Even if you're not sure if it's broken, if it's painful, splint it. It could be fractured, we just can't see it. Right, extremities that, so we're going to assess the patient's pulses, motor function, and sensory doing CSMs before and after splinting. Right, typical BLS. For signs of shock, place the patient supine, initiate IV therapy at the 30-20 mLs per kilo, depending on pediatric versus adult. Give high flow oxygen as needed. Okay, as needed. Keep the patient warm and prompt transport. Right, just because we can give oxygen doesn't mean we have to give high flow. Right, we don't want to over oxygenate, but if they are bleeding, we need to go with high flow oxygen to replenish what is being lost through the blood loss. As far as open injuries go, treat to minimize complications. Take standard precautions, address life threats and bleeding, tourniquet as needed, and then go to airway and breathing concerns. Don't waste your time holding pressure. If they are bleeding out with an arterial bleed, put on a tourniquet, shove some quick clot in there if you have it, move over to airway. Right? Direct pressure, pressure dressing, splints, tourniquets. Right? We can control our bleeding with that. If the wound is in the chest, upper abdomen, or upper back, cover it with an occlusive dressing. Chemical burns may be contamination should be flushed. All right, so apply bandages and wrap with a bandage. If a patient has chemical products on them, please do not put them in the ambulance until they are flushed and cleaned. Right? Do not bring a hazardous material into the ambulance. Right? A dressing directly covers the wound for dressing and bandaging to control bleeding. It's shaped in that specific pattern to trap platelets and help control and help promote clotting. Whereas bandages keep the dressing in place. So dressing over the bleeding, bandages keep it in place. The primary function, control bleeding, protect the wound, prevent contamination and infection. Utilizing sterile dressings, we have universals, we have 4x4s, 4x8s, 5x9s, 2x2s, trauma dressings. Everything's in a package, right? So it's sterile. Small adhesive tape dressings we have, occlusive dressings, self-adherent roller gauzes, everything that we're going to need to do to stabilize and treat the patient. Bandages, use soft roller bandages, roller gauze, triangular bandages, and adhesive tape. A lot of this stuff here, like I said, it should be all review on how to bandage a patient. But I've always thought as AEMTs to be trauma techs, right? Trauma clinicians, because you guys can do a lot for trauma patients. Complications of improperly applied dressing will be continued bleeding, additional tissue damage, or even loss of a limb. So always check the distal limb and bandage for signs of inadequate or impaired circulation or loss of sensation. Right? Know where all your pulses are located and where you can check for circulation. You can apply a bandage a little too tight, right? To the point where they actually stop circulation and cause more damage. So remember, we need to manage specific wounds. Avulsions, if possible, replace the avulsed flap in its original position if you can. And if complete, wrap the separated tissue in a sterile gauze and take it with you to the emergency department. Because they might be able to put that back on and save that avulsed skin. If it involves a large area of muscle mass, apply a tourniquet for an amputation and treat the patient for hypovolemic shock. Large bore IVs, fluids, based on a 20 or 30 ml per kilo. Right? I'm trying to remember, was there anybody in the class that was doing ride time with me when I had the avulsed foot? The almost amputated foot. I can't remember who it was. It was either Matt or Chandra with me that day. I had a student. I can't remember who it was. I had a third person with me. I don't remember who it was though. We had a lady, probably weighed about 400 pounds, came out of her house and stepped wrong and had an open tib fib fracture with like 99% circumference laceration to the point where her veins were actually coming out of her foot and actually clotted off themselves. I just don't remember who was with me that day on that call, but I had a student that day with me. I don't remember who it was. It looked just like this, but the foot was pretty bad. She got a lot of pain meds. She wasn't feeling much after I was done with her. So as far as bite wounds go, emergency treatment, remember, for bite wounds consist of prompt control of all bleeding and apply a dry sterile dressing. Dry. Immobilize the area with a splint or bandage and provide transport to the ED for surgical cleansing and antibiotic therapy. Most of the time, they're probably going to receive IV antibiotics to start, followed by a regimen of PO antibiotics for like 7 to 10 days. Penetrating wounds, we carefully identify all the wounds that are there. Entrance wounds or exit wounds are difficult to distinguish. Okay, so look for them. Count the number of wounds that are currently present. Damage from the gunshot wound directly related to the size, shape, and spread of the bullet, or speed, I should say, not spread. So try to determine the caliber of gun, and do not delay transport. If you don't know it, you don't know it, but don't delay. Abdominal wounds, if internal organs are protruding through an open wound, do not touch or move the exposed organs. Cover with a sterile gauze, compress is moistened with sterile saline and secure with an occlusive dressing over, as you can see here in the photo. Right? If the patient's legs and knees are uninjured, flex them to relieve the pressure of the abdomen. Kind of bend them up. If we have a neck wound or an impaled object, to stabilize an impaled object, look at the skill drill 28-1 in your books. If the object is very long, we're going to cut off the exposed portion first, securing it to minimize motion. Remember that if you have an impaled object and you are cutting it, okay, keep in mind that it does vibrate. It can cause more damage. So be very careful and stabilize it the best you possibly can. Right? This can be life-threatening. So for neck wounds as well. So cover with an occlusive dressing to prevent subcutaneous emphysema and air emboluses, and apply manual pressure, but do not use a compress. Do not use a tourniquet. Do not wrap it at all with gauze really tight. You can cause the patient to not be able to breathe anymore, right? And more damage. With burns, they occur when the body or the body part receives more thermal, electrical, or chemical energy, or is exposed to more radiation that can be absorbed without injury. So the pathophysiology behind it can also be systemic, where you can have damaged cells releasing vasoactive substances, creating an inflammatory response and increasing capillary permeability. Right? Fluid then starts shifting from intravascular space into the extravascular space, causing more edema, right? Especially if it's airway burns. Patients that have significant airway burns caused by superheated gases, right? And you actually open their mouth and you can say, oh my God, it's starting to swell. These patients need to be RSI'd and intubated, right? Significant airway burns, drownings. These patients can have significant edema building up, right? This is why we need to have intubation as fast as possible. So contact ALS, paramedic level, they come in. So reduction in the ability to regulate core body temperature with burns. What happens if you lose your ability to control body temp? Is that bad if you can't control body temp anymore?
Yes.
Yeah, shock. Yeah, you're right. So hypovolemia decreases cardiac output, resulting in hypotension, right? So we have a patient that's hypotensive now because they're hypovolemic, and all we're going to do is put more fluid into them, making Kool-Aid, when really they need blood products, right? We have to maintain a systolic blood pressure around 90 systolic based on PHTLS teachings, right? To make sure the patient is going to perfuse enough, but not over perfuse, becoming hypertensive, causing that bleed to bleed even more, losing more red blood cells, platelets, things like that, that transport that oxygen, which is why it's so important to put a patient on high flow oxygen, that's hypovolemic, right? Especially from bleeding. So a tough leathery substance known as eschar is produced. This can cause circulatory compromise and require an that. Having a moment of speaking those words out today. So hypovolemic shock occurs because of the fluid loss across the damaged skin and in series of volumes of shifts within the rest of the body. We just talked about that, right? It was trying to shift from intracellular to extracellular. We're losing that fluid. We're causing more edema. We're getting fluid into that third spacing, right? So coagulation disorders may also cause the blood to clot more easily as well. So resulting in emboli or a fail to clot, causing extensive bleeding. So they may be overclotting or underclotting. If that happens and they have overclotting, right, that can lead to something called DIC, which is like, we'll talk about that when we talk about sepsis later, but that can lead into that kind of stuff too, disseminated coagulopathy, causing a lot of clots to the point where they may actually have to lose a limb. So again, it could be overclotting or underclotting. All right. So complications of the burns would be high risk for infection. Sepsis is you have a high chance of getting septic with patients that have burns like this, right? Any kind of burn, really, like that protrudes through like past the first degree burn or superficial. Complete airway obstruction as well. We talked about superheated gases getting into the airway, causing a complete airway obstruction. Circumferential burns to the chest can compromise breathing, right? Because now it starts becoming very hard, like rock hard skin, right? Causing compression and like, I don't want to call it shrinkage, but shrinking around, not allowing for the chest to expand, right? Patients that have this happen will usually get their chest lacerated open to allow for that expansion to happen, right? And this will also circumferential burns of an extremity because of that tightness of the burn can also cause compartment syndrome, right? So the burn zones, so skin nearest the heat source suffers the most profound cellular changes. There are three pathologic progressions, one being the zone of coagulation, right, which is the central area of the skin that suffers the most damage. The second one is the zone of stasis, where peripheral areas surrounding the zone of coagulation, and the zone of hyperemia, which is the area least affected by the thermal injury. So there's three different layers. You're probably going to see these on your exams as well. So leave it here for a second. So as far as burn depth goes, right, we have the severity of burns is classified according by depth. Remember back in the day we used to call it first, second, and third degree? They've gotten rid of those now. And fourth degree burns was actually something that was taught many, many years ago at fourth, fifth, and sixth degrees, which describe deeper destruction, which we'll talk about here in a second. But the normal ones we see are superficial, partial thickness, and full thickness burns. So the superficial, or the old first degree, involve only the top layer of the skin, the epidermis. Partial thickness burn or second degree, those are a lot more painful, involve the epidermis and some portions of the dermis, where the full thickness burns extend through the layers and may involve the subcutaneous layers, muscle, bone, and internal organs. Usually when you get a full thickness burn, they're not going to be as in pain because they've now burnt off all the nerve endings in that area. Okay, so additional categories of burns do exist, such as fourth, fifth, and sixth degree burns, for describing deeper destruction, like going right down to the bone. So some burns cannot be accurately estimated, but you have to do the best you can to kind of figure out what body surface area is actually burnt, because we have to follow something called a Parkland formula, right? I don't know if Laurel went over that with you guys or not, but it's something you guys need to learn eventually, is the Parkland formula for, she did briefly? Okay. That's going to be for fluid resuscitation. In all reality, for adults with burns like that, we're not going to give or exceed that required amount in a short amount of time we have for our transport. So this figure here shows different layers of burns. So as you can see here, some burns, right? Notice there's no blistering. So this is going to be our first degree burn, or superficial sunburns. Sunburns can also get as far as second degree. I've actually had those on my shoulders before, and they start blistering. We start seeing that blistering, that's our second degree burn. We start getting down into the dermis layer, right? So we start here, first degree, second degree, and third degree. It starts including that subcutaneous fat, right? As you can see over here, our third degree full thickness burns over here, getting down into the subcutaneous layer. And then you can go as far as fourth, fifth, and sixth degree burns, getting down into the bone. So the bone severity, my goodness, burn severity. There are 5 factors that determine the severity of the burn: the depth, the extent, and the critical areas involved, whether it be the face, upper, airway, hands, feet, and genitalia. The pre-existing medical conditions, any other injuries that are present, and the patient is younger than 5 or older than 55 years of age. Upgrade the burn classification if the answers to the last 3 questions is yes. Right? What do we utilize to determine body surface area burned?
Rule of nines.
Yep. Now, is it different from child to adult? Yeah. So there definitely is a difference between the two. And what's something you can use as a rule based on percentage? The rule of what? Not the rule of nines, but your palm, right? How much is your palm worth? Yeah, 1%, exactly. We kind of get a rough idea if you need to do that. Remember that the genitalia is only worth 1%. Keep that in mind. All right. So the rule of nines, here we are here. So the rule of nines, based on dividing the body into 11 sections, each representing approximately 9% of the total body surface area. Rule of palms uses the patient's palm, including the fingers, to represent approximately 1% of the patient's total body surface area. So it's helpful when the burns cover less than 10%. So we kind of look at this stuff here in this photo. Looking at the photo here, we can tell the rule of nines. Okay. So each arm circumferential, right? 9 and 9. The back is 18, the front is 18, the genitals is 1%, legs are 18%, head is 9, right? But you can see it's a little bit different because the body is proportionally different based on pediatric and child. I'm not asking you, well, I am. You really should have this stuff memorized, especially the adult one, right? For burns. You should really have the rule of nines memorized so you can figure out your body surface area. They do make stuff in apps. They're in protocol books to kind of help review it. But you kind of need to work with it. You need to have these things done because we don't get a ton of burn patients. When we do, the last thing you want to do is be like, oh crap, I need to look at my protocol book and figure out rule of nines. So if you go to a burn call, bring it up on your phone really quick as you're responding out and take a quick look. Right? If you have any question what it potentially could be, because you need to get those numbers. It has to be documented. So assessment of burns determine whether there are other more serious injuries, right? So classify the burn to determine its severity. Avoid overlooking other potential life threats that require treatment. If they're bleeding out, we still need to stop it. So scene size up, MOI, number of patients, environmental hazards. If they're still on fire, they need to be put out first before you put them in the back of your ambulance. Well, why would we never have to do that? So consider potential for spinal injuries, inhalation injuries, and other injuries as well. Right? What are some things to look for when we have potential for airway burns? What are the things we look for indicators?
Blistering in the mouth.
What else are we looking for?
What was the question?
Tight chest.
So what are some signs that you would see for a patient that has potential for airway burns? And Justin put some down already. Soot around the mouth and nose, things like that to look for. So if you walk up to a patient and they have this, now we've seen this happen quite often. Actually, I think Mike, you're still on. I mean, I think you've been to a couple just in OSCP alone, where we've had patients with oxygen mishaps.
Yep.
Yeah, same patient probably more than once.
Oh yeah, same place.
Same place, same patient. So we look at all that, and we gotta be careful. Remember that oxygen is not flammable. It enhances burning, right? So it enhances the burn around that. So we gotta look for the superheated gases, what it potentially could do. All right. So our primary survey obviously would be a rapid full body scan using simple clues to identify severity of injuries and how quickly you need to assess them and treat them. So if you hear stridor, is that bad? Yeah. Stridor means the airway is starting to close up, right? Impending complete airway obstruction. Patients that have stridor need to be intubated, right? Albuterol is not going to fix this. Epi might help a little bit, but not much. These patients need to be RSI'd and intubated as sooner than later, right? Do not aggravate the injury at all, right? For anything that has to do with stridor, with burns. If the patient has singed facial hair, eyebrows, nasal hair, general impression may indicate airway or a breathing problem. If suspicious, be suspicious for clues that may indicate abuse as well. Consider the need for manual stabilization. Check for response to the ALPU scale, the life-threatening, bleeding, controlling, and signs of airway involvement. If they have hoarseness, cough, stridor, singed nasal or facial hair, carbon in the sputum, history of the burn in an enclosed space, request for a paramedic rendezvous with providers capable of performing intubation and other interventions as soon as possible. Be alert to signs for impending airway closure, right? That's stridor. Inspect the chest wall. Listen to lung sounds. Decap BTLS. Pulse rate, rhythm, and quality. Rapid transport. And if a burn center is not available, a level 1 trauma center is the next best option, right? Not every trauma center can handle high acuity burns, right? For the longest time, Maine Medical Center, level 1 trauma center, could only handle up to 20% burns. Anything other than that got shipped to Boston. I think now they can do a lot more. I'm going back about 10 years ago. Okay. They can handle higher burns now. Portsmouth Hospital, they could be a level 1 trauma center with an affiliation of a teaching university, and they cannot handle significant burns. They don't have burn units. They get shipped down to Boston, right? So think about where they need to go, and would flight make more sense? However, if you have airway compromise, they have to go to the closest hospital to get stabilized and shipped out, right? Please do not bypass hospitals because the protocol says, oh, the burns are here, take them to this hospital. If you're going to lose an airway, get them to the closest hospital first, and they can arrange for helicopter transport afterwards, right? They can still secure that airway as best possible that they possibly can. History taking, we're looking at investigating the chief complaint or history of present illness. Be alert for signs and symptoms, obviously, of the MOI. Be alert for injury-specific signs and symptoms and any pertinent negatives, like example, like no pain. If they're significantly burned and they have no pain, that's 3rd-degree burns all the way around. That's full thickness because their pain receptors are now gone, the nerve endings. Symptoms include pain or burning at the injury site. Sample history, obviously, you're having any difficulty breathing. So get your sample and then expand on it. Are you having difficulty breathing? Are you having difficulty swallowing? Are you having any pain? Right, go more in depth on that assessment. This is where the ALS assessment comes into play, is taking what you've learned and putting that to tailor your assessment based upon your signs and symptoms that you currently have in the complaint. Secondary assessment, conduct a more detailed physical exam or focused examination of the patient, utilizing your DCAP BTLS. Rule of 9s for estimated burns. We need to get that number so we can start fluid replenishment, right? So we got to get our rules of 9, and it's 4 mLs per kilo, right? We go through the whole entire process to be able to figure out how much fluid is actually going to receive, right? If you're going through multiple bags of fluid during transport, label your saline bags, 1, 2, 3, whatever it may be, so we know how much has been given, right? Just remember that we don't want to make this patient become hypothermic. Patients with burns lost their ability to thermoregulate, can become hypothermic very fast. All right, so we got to keep them warm. Look for soots around the mouth, soot around the nose, singed nasal hairs, and things like that. Listen for breath sounds. Assess the patient's neurological system, musculoskeletal system, vital signs, monitoring devices. End-tidal CO2, carbon monoxide monitoring, SPCO monitoring as well. Okay, so if you have the ability to do both SpO2, SPCO with end-tidal, that's going to help you tremendously. Then obviously reassess. Reassess your treatments, chief complaint. Has anything gotten better or worse? And reassess and reassess and reassess that airway until you get intubation in place. As far as emergency medical care, the proper emergency medical care may increase the patient's chance of survival and decrease the risk for duration of long-term disability. So check for traumatic injuries other than medical conditions that may be more immediately life-threatening, looking at the skill drill 28.2, right, and how to present and care for a burn. So goals are to stop the burning process, assess the treatment and treat breathing, support circulation, and provide rapid transport. We're going to provide spinal mobilization if needed. If signs of hypoperfusion are present, treat aggressively for shock, warm them up, lay them down supine, provide airway management, oxygenation, ventilation if needed, fluid therapy, replenish. Cover all burns according to local protocol. Right? What's our magic number for going from sterile or wet dressing versus dry dressing? What's our magic number per percentage? That's right, Matt, 10%. So anything 10% or under, we can go with a moist sterile dressing. Anything above 10% with wet dressings can cause hypothermia. Right? So during lengthy transport times greater than an hour, medical control may order you to administer IV fluids to the burn patient based on a consensus formula, which is formerly known as the Parkland formula. Now it's called consensus. Whatever. I'm going to call it Parkland formula because I'm old school like that. And that's what we're going to go by. So specific burns, like thermal burns caused by heat, a flame burn is often a deeper burn, is a deep burn. Hot liquids produce a scald injury. So coming in contact with hot objects produce a contact burn. I had significant burns one time, patient and a 1-year-old when I was working in Wolfboro years ago. And I ended up doing the 911 call, then transferring the kid down to Shriners afterwards. So a steam burn can produce a topical scald burn as well, and a flash burn is produced by an explosion. So I've seen a lot of patients with flash burns from barbecue grills, right? Because they don't know how to light grills appropriately. So these are different types of burns you may come in contact with. You need to document these and pass these along because some treatments may be a little bit different. Inhalation burns, most deaths from fires are caused by inhalation of toxic gases, upper airway compromise, or pulmonary injury. Superheated gases getting deep in the lungs can also cause what else to happen other than airway swelling? What else could it cause? Yep, we got burns. What are burns doing though? They're pulling from intracellular to extracellular. You're seeing a lot of fluid shift, right? What else is going to happen? Heated gas is getting into the lungs, pulling fluid. What else could happen? Fluid in lungs. What's that called? You guys still hear me?
Pulmonary edema.
Pulmonary edema, exactly. Good job. Right, so you got to watch for pulmonary edema as well. So this can occur when burns take place in the enclosed spaces without ventilation. Upper airway damage often associated with inhalation of superheated gases, but lower airway damage often associated with the inhalation of chemicals and particulate matter, right? So we get that inside, now we're starting to pull that fluid in, right? Intracellular to extracellular, we start seeing edema, right? And with edema, it can also cause pulmonary edema and fluid in the lungs as well from all these burns. So imagine having fluid building up in the lungs and then also having your airway close up and no way to remove that fluid, right? Which is why it's so important to get that intubation tube in place and getting paramedics on board. Carbon monoxide intoxication may also cause permanent damage to the organs. So consider whatever group of people in the same place all reported headache and nausea. Be suspicious of pulse oximeter readings when you are dealing with a patient with suspected or carbon monoxide poisoning. That's why I said earlier, if you have the ability to do SPCO, put the cable on that does both. This is why we should always have those on our monitors. This is my own opinion, by the way. This is why we should always have those on our cardiac monitors and not just the SpO2. I know they cost more, but it's already on. And by changing them out all the time is literally breaking the cables and the monitors more than anything else. So hydrogen cyanide poisoning, obviously gases from the cyanide present from smoke, smoke of the wood, certain plastics, or vehicle exhaust. Pre-hospital diagnosis is very difficult because laboratory studies are necessary to get cyanide gases. Signs and symptoms would include faintness, anxiety, abnormal vital signs, headache, seizures, paralysis, and coma. Might as well add death into that too. Right, chemical burns can occur whenever a toxic substance contacts the body. Eyes are particularly vulnerable to chemical burns, so wear the appropriate personal protective equipment. And in cases of severe chemical burns or exposure, consider a hazmat team. If we have a patient that has a powdery substance on their skin and is currently burning them, what do we do? Just wash it off? Put water on it? What do we have to do for this?
Brush it off.
Yeah, brush it off. What is something else that can be a very useful tool for that? Not brushing it off, but for documentation, for information, for chemicals. Something that has to be in a right to know station.
MSA,
MSDS.
material safety data sheets.
Yes. So MSDS, which now changed the SDSs because of global harmonization. That was a mouthful. All right. But SDS forms, right? Safety data sheets. They can provide us with a lot of information about that specific chemical, right? But there are other companies or another number you can call, right? to kind of help with chemical stuff, what would that be? Who would you contact? Poison control may or may not have that information for you for chemicals like that. They may. What's another company you can contact?
Chemtrax.
Chemtrack. Yep, exactly. And that number, I want to say it's like 1-800-424-9300. If I got that right, I'm really amazed. But I think that's what it is. I'm sure someone has a emergency response guide, flip to the front cover and look at the number. But if I'm right about that, I can't believe I actually remembered it. 424-9300 or something like that. I don't know. It's been a while. All right, so chemical burns, as you can see here. So the severity of a chemical burn is related to the pH level of the agent. So I'm not asking you to go in there getting little pieces of pH paper, dipping it in to see what color it goes, right? That's not what I'm looking for. But the safety data sheets may have that pH information listed on there, right? The concentration of the agent, length of time it was exposed to the agent itself, right? Volume of the agent, physical form of the agent, and treatment can be specific to that chemical agent that's there. So let me throw this at you. There is an app, right? And some of you may already have it, and it's called Wiser, W-I-S-E-R. You guys ever heard of that one before? So Wiser. That's an app that I believe it's free, that I'd recommend everybody have on their phone, because it teaches you how to handle certain chemical, it tells you like medical treatments for different chemical exposures, right? So if I'm responding to a call for a chemical issue and they actually tell me what it is over the radio, I will literally bring up the Wiser app, click on it. I will go into search a known substance. I will literally type in the name. And you could, if you guys had it on your phone, you could type in like propane, for example, and you go to medical on it, and it literally tells you the different treatments, health effects, and how to treat your patient with a propane exposure. It's a phenomenal app. I love it. I use it a lot. When I was a hazmat tech, yeah, W-I-S-E-R. I think I typed it out. W-I-S-E-R. Wiser. Right. When I was a hazmat tech, I used this quite often too. Years and years ago. Ooh, there we go. Almost done, guys. Almost done. So to stop the burning process, remove any chemical from the patient. Always brush a dry chemical off the skin and clothing before flushing it with water, because it may be water reactive. After brushing off the chemical, begin to flush the burnt area with large amounts of water. So not taking a saline and dumping it on the patient, literally putting them into a shower and flushing them off. Right, you're going to get wet. More damage can be caused by a chemical reaction of the antidote or neutralizing agent with the contaminant. So special management techniques like for dry Lyme, first remove the patient's clothing and brush as much as possible off the skin, then flush copiously with a garden hose or shower. It's not a quick rinse off, it's literally lots of water. Sodium metals, cover this type of burn with oil. What kind of sodium metal? Hydrofluoric acid is a calcium gluconate gel you'd have to utilize, which we do not carry. Gasoline or diesel fuel, most hydrocarbons are more effective removed with soap solution. With hot tar, immerse in the affected area in cold water. You get a hot tar burn. It is not within our scope of practice to apply burn ointments, which makes no sense at all. We're not allowed to do so, though. If the patient's eye has been burned, hold the eyelid open while flooding the eye with a gentle stream of water. As you can see here, they're utilizing the end of a saline bag, or I should say a drip set. Electrical burns, getting very close to the end. Contact with high or low voltage energy occur when the body or part of it completes a circuit connecting a power source to the ground, resulting in two burn injuries, entrance and exit wound. If it comes in, it has to come back out another direction. So you have to find both of those. Any patient that has an electrical burn needs to be on cardiac monitoring, needs to get a 12 lead as well, and continuous cardiac monitoring throughout the transport, because the electricity may have gone to the heart in some way and could have caused some damage. So there are two dangers specifically associated with electrical burns. One is the large amount of deep tissue injury and cardiac respiratory arrest from electrical shock. So never attempt to remove someone from an electrical source unless you are specifically trained to do so. Right? If they're currently being electrocuted, we cannot put ourselves at risk. You got to wait until the power is turned off. Always assume that a down power line is live. Even if they tell you it's not, always assume it is. Don't play jump rope with it or anything else. Just go over, go around it, step over it. Don't touch it. Right? Not all electrical injuries are the same. Determining voltage type and current if possible. Define whether the injury was brief or sustained for an approximate time of contact. So we need to get that information. Consider early definitive care of airway if the patient is unable to maintain their own. Look for signs of hypoperfusion and assess the heart rate. A taser use can create injuries that require emergency medical care as well, like with taser probes. So again, no line is safe to touch ever. I love it. Right? The way I look at it this way is cardiac monitoring is going to be key for anything electrical. All right, and if you suspect that you start seeing any kind of arrhythmias, put the pads on the patient because they could go into VTAC. Right, ventricular tachycardia is a lethal rhythm. It can be with a pulse or without, and it's also a shockable rhythm as well. So put pads on the patient, put a 4 lead on the patient, get a 12 lead, work around everything. Radiation burns, determine whether it's an ongoing exposure exists, and the amount of ionizing radiation will produce some type of damage. So there are three types of radiation that are out there: alpha, beta, and gamma. So the basic exposure pathways are inhalation, ingestion, and direct exposure. So this may result in burns and radiation sickness or radiation poisoning. The biggest thing to remember with radiation burns or radiation in general is time, distance, and shielding for what you have in front of you. How long you've been exposed to, how far away from you were you to that radiological material, and did you have any shielding? The best shielding for this is lead, but none of us walk around with a lead suit. Right? So again, time, distance, and shielding with anything with radiological burns. Right? How long were they exposed to it, and what type of radiation? Was it alpha, beta, or gamma? And to finish up, radiation sickness can cause premature aging or even death. So if not properly trained, maintain a safe distance and wait for a hazmat team to decontaminate the patient before initiating care. Right? Do not put yourself in harm's way. Establish IV access and give fluid based on patient presentation. Can we be exposed to radiation in the field?
Yes.
Yeah. So what happens if you have a motor vehicle accident with a tractor trailer unit that's carrying a bunch of portable x-ray machines? Is there enough in there to cause a problem? Is there enough radiation there?
Yes.
Yeah, there is. Right. So again, could that be alpha, beta, or gamma rays? Right. So you got to look at. So you need to get you need to figure out what they're carrying, how long they've been, what the exposure type may be, and how much they're currently carrying in their unit. So part of a requirement is anybody a CDL operator that's in the class?
Yes.
Yeah, I know Sean is.
Yes.
What has to be within hand's reach? So what has to be within hand's reach?
My MSCS sheets.
Yeah, the manifest of what's in the vehicle, right? The stuff that you are carrying currently.
Yes.
Yep. And they get into an accident, they're supposed to grab that and have that with them. Right? So that tells you what's inside the vehicle. So, Justin, you can talk about that for a second. We have a few minutes before we're done with the class anyways. If you want to bring it up.
When I worked at York Hospital in registration, every morning about 5:30, a vehicle pulled up in the front of the building. Kid walked out, he had a nuclear satchel, went into the nuke med area, dropped off, picked up. There was no markings whatsoever on his vehicle that thing was carrying nuclear materials.
Scary stuff, huh? You'd think they'd have to mark that kind of thing.
You would think, but it was about the size of a lunchbox.
Right.
Well, it actually depends on how much he's carrying for to be placard or not.
Right. So when you got a UPS truck or you have a Walmart truck driving down the road, they get into a crash, they don't have the placard because they don't carry the required amount for placarding, right?
That is true,
So,
but you got to remember that that truck is probably carrying a bunch of other chemicals that can be mixed together.
right, creating a bigger problem. So this is not a hazmat class, nor am I teaching you guys hazmat awareness, but Guide 111 in the Emergency Response Guidebook is where you would turn to if you have unidentified cargo. All right. So with that being said, almost 9 o'clock here. I'm going to stop the recording, touch base with you guys in a couple things, and then